Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 228 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, HPB, a 23-year-old man attended the out-of-hours medical service and asked about post-exposure prophylaxis for leptospirosis. HPB had fallen into a canal earlier that day, and had been fully submerged. HPB was taking isotretinoin for acne but was not on any other regular medication. HPB had no known drug allergies. He had no open grazes and had showered 1 hour after the incident. So my question to you is, what is the most appropriate post-exposure prophylaxis? Is it A, amoxicillin, or B, azithromycin, or C, doxycycline, or D, no prophylaxis required? Or is it E, trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D, no prophylaxis required. I will clarify why. The role of post-exposure prophylaxis for leptospirosis is debatable, with local guidelines varying. Current UK guidelines are that post-exposure management is limited to advice on showering promptly after water exposure, to minimize the swallowing of water and to thoroughly clean abrasions caused during the water exposure. The contraindication to doxycycline in this patient due to his isotretinoin treatment means that the most appropriate option is no antimicrobial prophylaxis, but heightened awareness and self-monitoring for fever and flu-like symptoms. Please proceed to the next question. And the next question reads, KOP, an 8-year-old boy was admitted to a hospital in Malawi with torrential rice water diarrhea. KOP was from a rural area where there had been a recent outbreak of cholera associated with contaminated drinking water supply. So my question to you is, what is the mechanism of action of the cholera toxin? Is it A, ADP ribosylation of elongation factor 2? Or B, ADP ribosylation of inhibitory G proteins? Or C, ADP ribosylation of stimulatory G proteins? Or D, formation of cation-selective pores in cell membranes? Or is it E, zinc-dependent hydrolysis of phosphatidylcholine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, ADP ribosylation of stimulatory G proteins. I will clarify why. The CTA1 subunit of the cholera toxin catalyzes ADP ribosylation of stimulatory G proteins, leading to elevated levels of CAMP intracellularly. This leads to an increase in intestinal chloride secretion and a decrease in sodium chloride absorption, resulting in a passive watery excretion, and diarrhea. The volume typically exceeds 10 milliliters per kilogram per hour in children and 1 liter per hour in adults. Please advance to the next question. And the next question reads, JNM, a 10-week-old infant was admitted to the pediatric intensive care unit with severe bronchopneumonia requiring intubation and ventilation. JNM suffered repeated apneic attacks. JNM had been born at full term by normal vaginal delivery, with no instrumentation. JNM's APGAR scores had been 8 and 9 at 1 and 5 minutes respectively. JNM had received her 8-week immunizations with DTaP-I, PVHI-B, PCV, meningococcal B and rotavirus vaccines 1 week before she became unwell. JNM lived at home with her parents, grandmother and 2 older siblings. Initial investigations revealed a lymphocytosis. Pause the video and carefully scrutinize the photo in this slide depicting the pathogen in this infant's case before progressing to the next slide. So my question to you is, what microbiological findings would be most consistent with this infection? Would it be A. bisected pearl colonies on charcoal cephalexin agar? Or B. blue-gray colonies on Thayer-Martin agar with vancomycin, colistin, and nystatin? Or C. gray colonies on Hoyle's agar with potassium tellurite? Or D. colonies on buffered charcoal yeast extract agar with L-cysteine which fluoresce yellow-green under UV light? Or would it be E. growth around combined X plus V disc only on nutrient agar? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. bisected pearl colonies on charcoal cephalexin agar. I will clarify why. This would be consistent with Bordetella pertussis, the likely pathogen in this infant as shown in the photograph in the above slide. Panasal swabs with a Dacron tip or nasopharyngeal aspirates are the specimens of choice, and should be plated at the bedside or placed in charcoal transport medium. PCR is more sensitive, especially later in the presentation and after antibiotics. The highest rates of disease in the UK are in infants under 3 months. It is highly contagious, with up to 90% of unimmunized household contacts developing the disease. Public health should be notified as contacts may need assessment, chemoprophylaxis and vaccination, that is, households with other infants below the age of 4 months, pregnant women and healthcare workers. Please proceed to the next question. And the next question reads, FTL, a 55-year-old man was clinically diagnosed with infective endocarditis of a native aortic valve. 3 sets of blood cultures were taken and FTL was started on empirical treatment with amoxicillin, dosed at 2 grams every 4 hours, and gentamicin, dosed at 1 mg per kilogram twice daily. Blood cultures grew gram-negative Cucobacilli isolated from 3 out of 6 bottles at 4 days. Adherent star-shaped colonies of 1 mm on blood agar at 37 degrees Celsius in enhanced carbon dioxide, that is, 5 to 10%, at 48 hours, catalase positive, oxidase positive, and non-hemolytic. So my question to you is, what is the most appropriate antibiotic regimen pending identification and sensitivities? Is it A. change to benzylpenicillin dosed at 2.4 grams every 4 hours and gentamicin dosed at 1 mg per kilogram twice daily? Or B. change to ceftriaxone 2 grams once daily and gentamicin dosed at 1 mg per kilogram twice daily? Or C. change to doxycycline 100 mg orally twice daily and hydroxychloroquine 200 mg orally thrice daily? or D. Change to vancomycin 1 gram twice daily and rifampin 600 mg orally twice daily. E. Continue amoxicillin and gentamicin. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Change to ceftriaxone 2 grams once daily and gentamicin dosed at 1 mg per kilogram twice daily. I will justify why. This is the treatment of choice for HACEK group endocarditis according to UK BSUC guidelines, especially as susceptibility to penicillin and amoxicillin is variable in Aggregatibacter actinomycetum comitans, the likely organism isolated in this case. Please advance to the next question. And the next question reads, SLM, a 56-year-old man presented with a slow-growing painless soft tissue swelling of the perimandibular region over 2 months. It had started discharging small amounts of pus through a small opening in the skin 2 weeks earlier. It had responded temporarily to a short course of co-amoxiclav but had then relapsed. SLM had no weight loss, fever, chills or other constitutional symptoms. He was otherwise in good health, worked in an office and had a long-term male partner. SLM smoked 15 cigarettes a day. There was no history of recent dental work or trauma to the face or mouth. On examination there was a firm 4 by 5 cm mass in his right submandibular region, tender to palpate and partially fixed on the deep tissue planes. The overlying skin was slightly bluish in color and there was a small sinus discharging thick yellow exudate. Investigations were done and the results were as follows. CT head and neck showed an ill-defined mass in the left piriform fossa involving the perimandibular gland and platysma muscle. The mass is infiltrative with crossing tissue planes, moderately enhancing with several low attenuating foci. There was no associated lymphadenopathy. A biopsy was performed. On direct microscopy, scanty gram-positive bacilli with branching filaments and diphtheroids and cocobacilli were seen. Modified Kinune stain turned negative. Regarding the bacterial cultures, they were aerobic, enhanced carbon dioxide and anaerobic cultures negative. Regarding fungal cultures, there was no growth at 25 degrees Celsius or 37 degrees Celsius. Regarding histology, there was chronic inflammation with the presence of multiple granules surrounded by polymorphonuclear leukocytes. An eosinophilic fringe surrounds the polymorphonuclear zone. So my question to you is, what is the most likely diagnosis? Is it A. actinomycosis, or B. mucormycosis, or C. nocardiosis, or D. nontuberculous mycobacterial infection, or is it E. tuberculosis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. actinomycosis. I will clarify why. Actinomycosis is most commonly caused by Actinomyces israeli, which may be a component of normal oropharyngeal flora. This chronic, invasive infection mimics malignancy as it may invade local muscle and bone if left untreated. Sinus tracts may occur. Oral cervicofacial actinomycosis is the commonest presentation, but thoracic and abdominopelvic infections are also seen. Diagnosis is usually by demonstration of gram-positive branching filamentous bacilli and sulfur granules. Cultures are rarely positive if broad-spectrum antibiotics have been taken. Please progress to the next question. And the next question reads, GTN, a 20-year-old man presented with fever, rigors, neck pain and respiratory distress. GTN had had a sore throat for the preceding week. On examination, GTN's heart rate was 148 beats per minute. His body temperature was 38.5 degrees Celsius and the blood pressure was 82 systolic 54 diastolic. His SaO2 was 89% on room air. Examination of the oropharynx showed erythema over the soft palate and swollen tonsils. GTN's neck movements were restricted and there was tenderness and induration over the right jugular vein. Investigations were done and the results were as follows. Peripheral white cell count was 28.7 times 10 power 9 per liter. The normal range is 4.0 to 11.0 times 10 power 9 per liter. His platelet count was 67 times 10 power 9 per liter. The normal range is 150 to 400 times 10 power 9 per liter. An X-ray of chest showed multifocal bilateral infiltrates. His CT neck is shown in the image below. Pause the video and carefully scrutinize the photo before advancing to the next slide. So my question to you is, what is the most likely causative organism? Is it A. Bacteroides fragilis, or B. Eikenella corrodens, or C. Fusobacterium necrophorum, or D. Streptococcus dysgalactiae, or is it E. Streptococcus pyogenes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Fusobacterium necrophorum. I will justify. Lemierre's syndrome is characterized by thrombosis and suppurative thrombophlebitis of the internal jugular vein. It is associated with disseminated septic emboli to the lungs and other sites. The most common pathogen is Fusobacterium necrophorum, but other organisms implicated include Eikenella, Bacteroides and streptococcal species. Organisms may be isolated from blood cultures and from infective metastases. Please proceed to the next question. And the next question reads, RTT, a 58-year-old woman developed an abrupt onset of high fever, which she had measured at home as 39.1 degrees Celsius and flu-like symptoms. RTT presented 4 days later when a generalized rash appeared. RTT had returned 3 days before the onset of fever from a 4-week visit to family in Turkey in June. RTT had diet-controlled diabetes mellitus and well-controlled hypertension. RTT was taking regular amlodipine and lisinopril. Her family lived in a rural village in the Trakya region of Turkey. On examination, RTT was alert and oriented, and her temperature was 38.3 degrees Celsius. RTT had a widespread maculopapular rash which spared her face but involved her palms and the soles of her feet. There was an eschar on the medial aspect of RTT's lower left calf. This was not associated with any edema or regional lymphadenopathy. Serology and blood cultures were taken and a punch biopsy of the eschar performed. RTT was treated presumptively with oral doxycycline for 7 days. So my question to you is, what is the primary target of the likely causative organism? Is it A. endothelial cell, or B. erythrocyte, or C. monocyte, or D. neutrophil, or is it E. striated muscle cell? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. endothelial cell. I will clarify why. This is a case of Mediterranean spotted fever as characterized by the eschar, high fever and maculopapular rash. This is caused by infection with Rickettsia connery subspecies connery. SFG rickettsia are injected by infected ticks while feeding, which then adhere to their primary target, the endothelial cell. Adherence leads to phagocytosis and then release of the organisms into the cytoplasm of the infected endothelial cell. Although rickettsia are obligate intracellular organisms that can infect vertebrate endothelium, vascular smooth muscle and macrophages, it is the endothelial cell that is the most important target cell. Please progress to the next question. And the next question reads, EAK, a 47-year-old man presented with an intensely painful ulcer of 13 days duration over the glans penis, surrounding the urethral orifice. The lesion had started as multiple small superficial ulcers which had then coalesced. The ulcer had distinct raised thickened erythematous edges. There was necrotic slough and a foul-smelling hemopurulent discharge. The penis was edematous and there was bilateral tender inguinal lymphadenopathy. EAK had had unprotected insertive and receptive anal sex with at least 20 men in the preceding 3 months. His investigation results were HIV-AGA-B negative and syphilis EIA negative. His direct wet mount microscopy showed trophozoites containing ingested red blood cells as shown in the photograph in the next slide. Pause the video and carefully scrutinize the photo of direct wet mount microscopy before advancing to the next slide. So my question to you is, what is the most likely diagnosis? Is it A. Balamuthia mandrillaris, or B. D. Entamoeba fragilis, or C. Entamoeba histolytica, or D. Giardia lamblia, or is it E. Trichomonas vaginalis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Entamoeba histolytica. I will clarify why. Primary infection of the skin by Entamoeba histolytica can be acquired by direct contact with an infected subject during vaginal or anal intercourse. Identification of trophozoites containing ingested red blood cells is consistent with a clinical picture of amoebic infection. Biopsy may be necessary to demonstrate trophozoites and to exclude other diagnoses such as squamous cell carcinoma. PCR may be useful in confirming the diagnosis. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 229.